Right. So in my presentation, I would like to share with you some lessons learned from maternal death reviews and severe morbidity reports. And I am going to touch a little bit on basics of obstetric anesthesia. And then I hope to discuss few clinical scenarios with you all. I have prepared about 5, and if time permits, we'll see, depending of the availability of time. I'll try to discuss as much as possible. Okay. Right. One survey in the United Kingdom some years ago, this question was asked from junior anesthetists, right? What has been the most stressful, difficult, or frustrating anesthetic experience or scenario that you have had to manage to date? So more than 80% of the junior anesthetists answered as saying obstetric on call. This may be different in our country, especially for those who are working in, the maternity hospitals. But this is, I think, probably for those who are working in general pool and doing obstetric on calls as well, right? So 80% of them said obstetric on call was the most difficult or frustrating anesthetic scenario, right? So some of their worries were managing certain emergencies such as severe antepartum hemorrhage, eclampsia, and so on, right? And dealing with failed spinal and intraoperative pain. That is, it's a very, very embarrassing situation when the spinal is not working, or when the mother is complaining, and then you don't know what to do. When the mother is complaining, and whatever you do, it's not going to work. Like, so it's a difficult situation. And then sometimes dealing with pressure from obstetricians, especially in hospitals where there is no consultant anesthetist. The obstetrician is trying to give you instructions and do this way, that way, and all that. So it's a real pressure sometimes. And then the other one is the anesthetic technique is blamed for fresh IUD. We all experience that, trying to put the blame to the anesthetist when the fault is really from the other side. So these are some worries of junior anesthetists. Right. So keeping that in mind, now we will move to this. What is expected from medical officers in anesthesia? So one thing we want as senior, anesthetists, we would like you to work as, part of a team. You are a member, and sometimes you may have to work as the leader in a team, right? And always try to maintain a happy, peaceful, and friendly environment in the operating theater, so that when you enjoy your work, then you can do a better job than working under stressful, unhappy circumstances. Right. Then you should be able to identify high risk pregnant women by taking a proper history and examination and communicating all that to the consultant anesthetist, or when there is no consultant anesthetist, discuss with your senior MOs and come to a decision. And then you should be able to provide a safe anesthetic for the normal or the low risk mother, elective or emergency situation. So normally the pregnant mother belongs to ASA 2 category. So always in the ASA 2, the normal mother. So then the complicated mother is falling in 3, 4, and so on, right? Then in some hospitals, the pain relief in labor also should be part of the MO's work, at least to help the registrars in maternity major hospitals. So that is also the MOs. We expect MOs to know about pain relief in labor and contribute to that part as well. And then one of the most important thing is, apart from providing anesthesia, is that resuscitation of a collapsed pregnant mother, where the anesthetist has a major role to play, and sometimes to take the leader's role. And also the anesthetist should be aware, should know the differences in the resuscitation of a pregnant mother. So should be applying those things in in clinical practice there. And then transferring a critically ill mother. Now, what are the things you should know? The monitoring, what monitoring you should take with the patient, then how to manage vital functions, especially when to intubate that critically ill mother. All these things you should be, you should know very well, and you should have a clear picture what should be as to what should be done. Now, talking about maternal mortality, I thought we can learn a lot from these maternal deaths, a lot of lessons. So I thought it's good to tell you a little bit about the maternal mortality and near misses too, and what lessons we can learn. So now the latest report, the reported maternal mortality ratio available up to date is for the year 2022. That year, the maternal mortality rate had been 33 per 100,000 live births. Right. Now, what are the causes of maternal deaths? Now, you can see in that year, the number 1 and 2, heart disease and respiratory diseases, and CNS diseases in the third place, where the strokes, cerebral hemorrhages due to, severe the pre-eclampsias and eclampsias are also included in there, right? And obstetric hemorrhage had been in the fourth place. Then you can see ectopic, ruptured ectopic in the sixth place. Now, can you see any anesthetic deaths? No, you can't see any anesthetic death or anesthesia-related deaths. So it's a very good thing, isn't it? Not even in the last thing is the malignancy, you can't see the anesthetic deaths. But now you can see in UK, in the United Kingdom, there had been, I mean, it's very small numbers, but there are deaths. Now, even in that year you can see, this is what I could find as the latest in the triennium for 3 years, 1 death, anesthetic death, right? And in the other years also, there are deaths per 100,000 maternities, very low, but there had been deaths. Okay. So, but in our country, you can see no deaths from the year 2007 up to 2022. Now, no deaths, 0, 0, no anesthesia contributing deaths. Is it very, it's very good, it appears, are we delivering very good anesthetic service to our patients? But I think there is some issue there, not reporting very well or not recorded. So there must be a problem. But it appears that our services are very good. Our obstetric anesthetic services are very good. Now, in this table, you can see anesthesia-related problems, maternal mortality in low and middle-income countries. Now, here you can see the number of events under general anesthesia and regional anesthesia. So maternal deaths, you can see 138 here, under regional 25, cardiac arrest 21 under general, then under regional anesthesia 10. Even the fetal, more number of events, the low APGAR scores with general anesthesia than under regional. So it seems that the regional anesthesia is much safer for the pregnant mother. Right. So now the other thing I want to tell you is that the preventability of maternal deaths, more than 50, always, every year when we analyze, we have found more than 50% of the maternal deaths are preventable. So as anesthetists also, we can contribute a lot to minimize these deaths. The contribution from the anesthesia side or working in a multidisciplinary team, manner, to save the mothers. So now talking about maternal near misses or severe morbidity, you can see this is not investigated, every year like the maternal deaths, but in the year 2016, this was analyzed in some district in our country, and they found that again hemorrhage and hypertensive disorders were the main causes of severe morbidity or near misses. Right. So, what is a near miss? Now, where a mother nearly died but managed to survive. Now, there are some criteria. I am not going to go into details, but just see whether, as anesthetists, we can cause these near misses. Now, cardiac arrest may occur due to our anesthetic reasons, but always trying to, taken it as due to some other cause, right? Cardiac arrest. Then say severe bradypnea or respiratory difficulty, and then respiratory arrest. Then global paralysis, intubation due to not related to anesthesia, say high spinal and then respiratory problem, and then we have to intubate. So there are near misses, but the problem is these things are not been reported, and we don't know what's happening. That is the situation in our country. Now, see, in the United Kingdom, though the cardiac arrest in pregnancy is a rare situation, 1 in 36,000 incident, out of those cardiac arrest, 1 out of 4 cardiac arrests had been due to complications of obstetric anesthesia in UK. And what they say is the main association of collapse in obstetric anesthesia actually due to epidural spinal or combined spinal epidural. And most of these women were obese, 12 out of 16, 75% were obese. So you can see obese patients, we have to do a proper care, we have to give a proper anesthetic, very carefully planned anesthetic. Right, and it is quite common, but all these patients were resuscitated and they survived. There had been no deaths, but cardiac arrest under anesthesia due to our anesthetic technique, whether it is epidural. So this is not GA. This is due to regional anesthesia. So these things are happening. So we must always try to take measures to prevent these things happening. And we can't just be happy saying our anesthesia is very good, no deaths. We can't be happy like that. We can do a lot to minimize these critical incidents or near misses, right? Right. So anesthetic deaths or anesthesia contributing to deaths or severe morbidity, no deaths in our country reported. So these, I think, the spinal related or the regional anesthesia related problems, we don't recognize. Right, we all usually in our country those things are those cases are reported as due to some other cause like amniotic fluid embolism or anaphylaxis, like that. And then that's due to GA is very clear. It's very obvious. Everybody can see the airway difficulty, the mother desaturating and then arresting, very obvious. Whereas the regional anesthesia related complications are hidden, not coming, not very obvious. So that is the reason probably we are not reporting any cases in our country because we are not doing an in-depth analysis. Right. So major issues identified in the year 2018 are suboptimal care, guidelines not followed. The PPH and preeclampsia guidelines have not been followed in the management. Different methods or techniques had been used to manage these patients. So that is not good. Then late interventions, lethargic approach, and lack of input from an anesthetist. In one situation, I can remember very well, In that hospital, there was no consultant anesthetists, but there were five MO anesthetists working. But they worked only during the daytime. After 4, there was no MO available to do anesthetize patients for emergencies. Sorry about this. So that a mother ruptured ectopic was admitted, and the obstetrician couldn't do the operation because there was no MO to anesthetize that mother. So he had to transfer the patient, and on the way she had a cardiac arrest and died. So these things still, from time to time, we see cases like this. So that is not a good thing. So lack of input from an anesthetist when it was necessary. Sometimes the anesthetist was not informed in the resuscitation. So these things are still happening. Then the monitoring was poor, substandard documentation, then administrative failures with that non-availability of essential drugs and so on, right? Okay, now coming to basics. Just excuse me. Right. The pregnant mother is different. You know, there are physiological changes occurring in pregnancy. So we have to always take a pregnant mother not the same as any other adult. There are things we have to take into consideration when managing a pregnant woman. So always we have to be aware about that and take appropriate measures at the appropriate time. And regional anesthesia is safer than general anesthesia in most of the patients, even in complicated situations. Now, talking about elective cases, uncomplicated pregnancy, we can follow the standard practice, and always we have to be ready to manage unanticipated complications such as hemorrhage. Unanticipated hemorrhage may occur at any time. Pregnant mother is at risk of bleeding at any time. So we have to be ready. We can't just relax, be ready to handle unanticipated complications. Now, when we come across a complicated pregnancy, by proper planning, especially in the elective situation, proper planning and preparing well, and discussing with the consultant and planning very well, we can overcome all these most of the issues. In emergency situations, we must identify the priorities, especially know the category of cesarean section, and find out whether it is a maternal or fetal reason, and then optimize the mothers and the not only the mother, the fetus as well, by giving intrauterine fetal resuscitation. So we can do a lot to improve the condition, and then provide a safe anesthetic tailored to that particular patient, not in a fixed manner. You must, we should be able to adjust the technique according to the, depending on the patient's problems. Right. Then the other things, just like in any other, field of anesthesia, all these checking equipment, drugs, all these things are very important. I'm not going to go into details. And there is a WHO checklist for the pregnant patient. In some of our hospitals, this is available, developed by the obstetric committee. So they are, by using this the surgical safety checklist, we can minimize. It has been shown to reduce complications, 30% less, so 30% reduction in problems. So therefore, it is very, very important to use these checklist whenever possible, and try to use. I know this is not available everywhere, but we can use. I think in future it will be available to every hospital. So it is very, very important to use. There are some differences even for the category 1 cesarean section. You have to fill this later, may not be just before, but afterwards, at least after attending to the emergency situation. So now there are a lot of physiological changes happening in the pregnant mother. So I am not going to talk about the physiological changes in pregnancy, but the clinical implications I would like to mention few. So taking the cardiovascular system, the main change is the increase in blood volume and the cardiac output, so that the pregnant mother can compensate blood loss, and signs may not appear until late, and sudden cardiovascular collapse may occur. So we must always suspect the hemorrhage, because we cannot rely on signs and symptoms most of the time. This is called masking of physiological, the masking of symptoms by the physiological changes. Then the mother with cardiac disease, sometimes during antenatal periods, symptoms and signs may not be present, but the anesthesia can precipitate life-threatening complication. For example, the peripartum cardiomyopathy. So that we have to be very careful. It is very important to take a proper history and examine and do the investigation, especially asking for a echocardiogram when you suspect. It is very important. And good analgesia, labor analgesia, will reduce the workload during labor. And the supine hypotension is a major problem during for the pregnant mother, especially for the compromised mother. Even the hypotension due to subarachnoid block can be worsened by the supine hypotension. So this left lateral displacement of the uterus is very important. Right. The respiratory, again, now, no nasal intubations, because the nasal mucosa is congested in the pregnant mother. So we shouldn't do any nasal instrumentation. They desaturate very fast. I don't have to explain. I think you are already aware of all these things. Just reminding you the problems, airway is more difficult. So it is very important to assess the airway, give aspiration prophylaxis. Pre-oxygenation is also very important, right? And always be ready to handle a difficult airway. And when you are ventilating, try to mimic normal respiration, because pregnant mother is hyperventilating, the alveolar ventilation is increased. So little bit you have to hyperventilate, keeping carbon dioxide tension around 30 millimeter mercury, and they can tolerate a fairly high regional block with intercostal paralysis, because they are more dependent on the diaphragmatic breathing. Then the GIT, again, they are at very high risk of aspiration. So important to give the aspiration prophylaxis to reduce acidity and the volume. And if you don't give aspiration prophylaxis, and if that mother aspirates, very high chance of death, high mortality, right? With general anesthesia. Therefore, it is important. Modified rapid sequence induction is the method recommended to induce general anesthesia in the pregnant mother. So pre-oxygenation is important, and no positive pressure ventilation before intubation unless the mother is desaturating. And always we have to intubate and then cuff the tube. This is mandatory. And cricoid pressure is important, and maintain until the tube is confirmed and the cuff is inflated. Right. And if the mother had a solid meal, in the emergency situation, if you had to give general anesthesia, then it is advised to put a orogastric tube during the surgery and do a gastric lavage, and then remove the tube before extubation, right? So that we can prevent aspiration at the time of extubation. Right. Now talking about CNS and skeletal changes, again, the local anesthetic dose requirement is very much reduced, and the epidural pressure can increase the level of the spinal. Even with a small dose of the spinal bupivacaine, small dose, if there is the collection of saline or even the local anesthetic in the epidural space, then the volume that is called epidural volume extension, and that can cause a high block. So we have to be very careful when giving combined spinal epidurals to pregnant women. And the other thing, during contractions, the uterine contractions, if you inject local anesthetic, it can produce a higher level of block. And the dose requirements of GA drugs are also reduced. And in lateral position, the subarachnoid block can spread to a higher level because of the width of the shoulder width is higher than the hip, right? So it can happen. Okay. And then the pregnant mother is in a hypercoagulable state, so there is a risk of venous thromboembolism. So we have to follow all these guidelines, right? And the fibrinogen level is quite high, double that of the non-pregnant. So that is the factor that drops as the first thing during postpartum hemorrhage, and that is the factor we have to replace first during postpartum hemorrhage. And sometimes the succinylcholine may work for a longer period because of the pseudocholine esterase levels are reduced during pregnancy, right? So these things can happen. And the colloid osmotic pressure is reduced in the pregnant mother, so that they are very prone to develop interstitial pulmonary edema, especially in the presence of preeclampsia. This is worse. They are at very high risk of developing pulmonary edema, so that we have to be careful when giving fluids to these women. Coming to categorization of cesarean section depending on the urgency, I think most of you all know about this. Category 1 is emergency cesarean section. Category 2 is urgent. Category 3 scheduled, and category 4 is elective Caesar. So category 1 is when there is immediate threat to the life of the mother and the fetus, and the delivery should be done within 30 minutes. But now we know there are some cases even within 30 minutes is not sufficient. We have to make it more, the time limit is very much less. So therefore it is categorized now as 1A and B. So 1A needs delivery within 15 minutes and 1B is within 15 to 30 minutes. So that anesthetist should know about it. Actually, when an emergency or category 1 Caesar is brought to the theater, we should worry about is not about the mode of anesthesia, but the time. So we should be able to provide our anesthetic within this time. That is the important thing, right? Now we'll go to some cases. Now this patient number 1, this patient is in a peripheral hospital where there is no consultant anesthetist, right? No consultant anesthetist, and the patient is a 25-year-old primipara with a POA of 26 weeks, present to the OPD with a history of epigastric pain since morning the same day, and she had vomited twice and had developed 3 convulsions on the way to the hospital. And another convulsion just she had in the OPD as well. And her GCS is low, 10 out of 15, and her blood pressure 180, 110. And the SHO has treated her with hydrolysine, 2 boluses, 5 milligram boluses. And the MO, who is on call MO anesthetist, has been requested to see the patient before transferring to the tertiary care hospital, because the VOG is also on leave and they can't manage the patient there. Right. So in a peripheral hospital, this can happen. So as the MO, what would you do? Right. So you have to go and see the patient immediately, identify the patient as an eclamptic with complications. You can't take it as a simple eclampsia, because she had vomiting, epigastric pain and all that. So we have to suspect HELP syndrome. And in addition, now with low GCS and several convulsions. So we have to suspect cerebral hemorrhage as well. So the treatment wise, we must prevent further convulsion. So magnesium sulfate is indicated. So we have to give the proper dose, 4 grams over 5 minutes. So the magnesium should be diluted in 100 ml saline and give it over 5 minutes. So these doses and the times are very important. Then only it will, if you give it slowly, then the proper effect will not happen. The patient might throw another convulsion. So these things are, we should follow the guidelines. Following guidelines means that the correct dose and giving it over the correct time, right? Then only we can get the necessary treatment, or the patient will respond to it in that way only. And then start the infusion 1 gram per hour, and this has to be given through a bigger cannula, 17 to 16 gauge, and then need to control the blood pressure. So she already received hydralazine, but if the pressure is still high, you may have to start hydralazine infusion, or if labetalol is available and if there is no contraindication like asthma, you can use labetalol IV 20 milligram boluses to control the blood pressure to a safe level 140/90. And now this patient needs intubation and ventilation before transferring. If you try to transfer without intubating, what will happen on the way? So you should be able to predict these things. If I transfer this patient without intubating, on the way she might aspirate and she might have another, convulsion, then the airway is not protected. So a lot of problems can happen. So therefore, it is very important to intubate this patient. And then need IV fluids, you may have to give, IV fluid, 5 milligram, 5 ml per kg bolus, and then the maintenance, 1 ml per kg per hour, and catheterize the patient and start monitoring the urine output, and then discuss with the consultant anesthetist in the receiving hospital and make sure that there is a bed available, and discuss if you are not sure how to intubate and what is to be done before transferring. You can discuss, okay? And then you will have to accompany the patient with all the monitoring and emergency drugs. Now, how do you intubate this patient? So you may not be able to do it alone. So if there is another anesthetist, better to have a second anesthetist with you. And now you must give magnesium and treat blood pressure as aspiration prophylaxis given, and then have all the difficult airway equipment and do this intubation preferably in the operating theater on the operating table, because then you can adjust the table, can be minimized in that way. And you have to use proper anesthetic drugs. It is not midazolam and suxamethonium as normally you intubate any other patient. Here you have to give proper anesthetic drugs, right? And modified it with fentanyl to reduce the intubation response to laryngoscopy with the risk of further increasing blood pressure. Now this patient may be already hemorrhaged or about to hemorrhage. So at the time of intubation, this can happen. Cerebral hemorrhage may occur. So we want to minimize that happening, or if she has already hemorrhage, not to aggravate it further, right? So intubate with size 7 endotracheal tube. Use a smaller tube and fix it properly and start ventilating. And you need to sedate the patient using propofol or midazolam, fentanyl, and then only take the patient to the other hospital. So this is how to intubate and then transfer the patient. Now take the second patient. She's a healthy primipara, just received a spinal anesthetic for category category 1, I think category 1 cesarean section, her blood pressure dropped to 80 by 50 from 130 to 70. Now, what will you do? Now, our aim should be to take the blood pressure the more than 80% of the baseline, that 130 blood pressure, now it has dropped to 80. So our aim should be to keep it at least 100 millimeter mercury, right? The hypotension, keeping hypotension is a big issue. I'll come to that later. So you have to aim should be that, and then co-load fast with your crystalloid, normal saline or Hartmann 500, then increase the tilt, left lateral tilt, because supine hypotension will also add to this, and it will be very difficult to treat hypotension when there is supine hypotension on top of that. So you increase the tilt, frequent monitoring, and then you have to give vasoconstrictor boluses. And if phenylephrine is available, you can start infusion of phenylephrine and treat bradycardia at the same time. And if the saturation drops, you will need to give oxygen also to keep the saturation above 95%. Why is it important to treat hypotension? Because of the adverse effects on the mother as well as the fetus. On the maternal, it can cause vomiting and then faintishness, and finally it can cause even loss of consciousness due to poor cerebral circulation. And then it can cause severe bradycardia and cardiac arrest even. Then in the fetus, it can cause bradycardia and acidosis, because the fetal blood flow is, uteroplacental blood flow is mainly dependent on the maternal blood pressure. So it is very important to treat the hypotension. What could have been done to minimize the severity of hypotension? Now, this hypotension for cesarean, spinal anesthesia-induced hypotension with cesarean section is anticipated because we need a T4 sensory block. So invariably there should be some degree of hypotension, but what we want is to prevent severe hypotension. That is the aim. So therefore, co-loading is very important, and this should be the first 500 ml should be over by the time they deliver the baby, or when the spinal is working, starting to work, the first 500 ml should be over. Like, that is just a rough guide, right? Co-loading with 500 ml crystalloid, then using avoid high doses of local anesthetic. We must use a smaller but adequate dose, individualized dose according to the patient's weight and height. So it is not a fixed dose for each and every patient. That is what I want to say. You must adjust according to the patient's weight, height, BMI, and so on. And then in a difficult situation, when there is a very short mother or morbidly obese woman, when it is difficult to judge the dose, the safest thing is to give a combined spinal epidural with a smaller subarachnoid dose, so that then top up with the epidural, so that we can avoid this hypotension. Then always put this tilt, left lateral tilt, as I told you earlier, to prevent aggravating spinal-induced hypertension with the supine hypertension syndrome. Then the prophylactic vasoconstrictor infusion, the phenylephrine infusion is recommended by the International Consensus Statement 2017 to use 25 to 50 micrograms per minute infusion prophylactically without waiting for the hypotension. Now, the problem in our country is we don't have phenylephrine available freely. We have to use it selectively, especially in cardiac patients and all, because it is expensive compared to ephedrine, right? So which vasoconstrictor is better to manage spinal-induced hypertension? Phenylephrine is the better drug. But the problem is bradycardia. So always we have to look for bradycardia and treat bradycardia, and it is more expensive, and we can use it selectively in heart disease, but it is the recommended drug to minimize spinal induced hypotension in obstetrics. The ephedrine, the problem is it can cause fetal acidosis due to increased metabolic rate of the fetus, because it crosses the placental barrier, placental transfer, and cause increased metabolism in the fetus and causing fetal acidosis. So therefore, the phenylephrine is a better drug. So what is the cause of hypertension? Because of the vasodilatation due to sympathetic block. And this is a rapid onset with the spinal anesthesia. And so the higher the cranial spread, more the hypertension. When block is above T8, when the adrenal medulla is blocked, all these baroreceptor activated the response is less effective because of the adrenal medullary block. So therefore, invariably the hypotension will occur when the block is going above T8. And then when there is a sympathetic block, there is a parasympathetic predominance. So there will be bradycardia. In addition, when the venous return is greatly reduced, there are other reflex mechanisms occurring in the left ventricle causing bradycardia. And when the block is going above T4 level, there will be cardiac sympathetic block with bradycardia. So all contributing to hypertension. Okay. Then the third case, I think there is a little time. I'll try to finish with the third case. A previously healthy 38-year-old G3P3 C3 mother complained of dizziness when trying to turn to a side 3 hours following a normal vaginal delivery. She was given 500 normal saline, 500 ml normal saline, and by the house officer. And then the blood pressure had dropped to 90/50, and heart rate is 110 per minute. And you have been asked to see the patient. So the MO, when you are the MO on call, and you have been asked to come and see the patient. So what would you do? Now you have to attend to the patient immediately without delay. Now you have to suspect here the postpartum hemorrhage, and it is very unlikely it's amniotic fluid embolism or thromboembolism or anaphylaxis, but keep that also in mind. But it's very likely, the most likely one is postpartum hemorrhage. And at the same time, you have to make sure that the senior obstetric team members also have been informed, and you have to start with the ABCDE approach of resuscitation. And so as soon as you attend to the patient, you must see the risk level, right? When the MEOS is more than 7, the MEOS score, or the other one is the shock index, which is heart rate divided by the systolic blood pressure. If it is more than 1, it is abnormal. Now, in this patient, heart rate is 110, the blood pressure, systolic blood pressure is 90, so the shock index is 1.2. So now when the shock index is 1.2 and the MEOS more than 7, so that patient is at very high risk of collapsing immediately. Now, at the moment, she is okay, just compensating, but she would collapse if we don't do anything immediately. Aggressive management is needed. So now the WHO has recommended this, what is called emotive approach. So this has to be completed within 15 minutes of detecting postpartum hemorrhage. So what is E? E is early detection. So what are the trigger criteria for that? Even 300 ml of blood loss. No need to be 500. Now we normally know when the blood loss is more than 500 ml, we take it as postpartum hemorrhage in the definition. But 300 ml with tachycardia and other signs, with one or more other abnormal observation, you have to start the resuscitation, the emotive, right? So starting M is uterine massage, O is oxytocin drugs. Though the WHO has recommended 10 units in our country, the multidisciplinary team has decided that 5 may be in a already hypotensive patient. If you give 10 units IV, that can cause further hypotension, and mother, even she can collapse. So it's not safe. We still we want you to give 5 units and start the infusion. 10 the maximum rate, 10 units per hour infusion, and give tranexamic acid. Again, you have to give it slowly. So they advise, the WHO advises to dilute it in 200 ml, give it over 10 minutes, but because it takes time to prepare all this, emptying the 500 saline to 200 and adding it and all, we can give it, draw the tranexamic 1 gram, that is 10 ml, into a 10 ml syringe and give it slowly, right, over 10 minutes, not to give it rapidly. That is the important thing here. And then to give IV fluid, boluses, and insert 2 large bore cannulae. And E in emotive is the escalation, examination and escalation, where look for empty bladder and look for tears, the vaginal cervical tears, and suture them. And if there is no if the still bleeding is continuing, we have to escalate the treatment. So this is the initial management. These emotive 1, 2, 3, 4, 5, 6 things should be completed within 15 minutes. That is the most important thing here. We have to understand. So as anesthetist, even in the theater after cesarean section, same thing you have to apply. So this is for the normal vaginal delivery. Now we are discussing it. This is any postpartum hemorrhage situation, right? So because of the time, I have to go through this fast. So you have to take all these steps simultaneously while preventing lethal triad. The monitoring, calling for help, informing the senior, the consultant anesthetist as well, and control the bleed, because most of the time the consultant anesthetist is not informed, right, until all the problems happen. The MO or the registrar is trying to manage all alone. So this is not correct. At this stage, the consultant also should be informed and take all the mechanical, surgical, and medical measures to control bleeding. Take blood samples, 20 ml blood for the investigations, including venous blood gas, to look for acidosis, and take rotem sample and INR-APTT, fibrinogen, and ask for blood, 6 units with cryo, platelet, and all these things, and continue monitoring and communicate. And the decision should be made now whether to take this patient to the operating theater. So the lethal triad here, it is very important to prevent the development of lethal triad. So what are the measures to prevent lethal triad? We have to avoid hypothermia by warming the patient, warming the fluids, and monitoring temperature if possible, and trying to keep the temperature 35 or 36, and prevent metabolic acidosis by maintaining at least systolic 80, and minimizing the saline, because if you give large volumes of saline to resuscitate, this acidosis may increase. It is hypochloremic acidosis, and ring galactate is the preferred solution. Anyway, the total crystalloids also should be minimized. You must start replacing blood loss with blood as early as possible, even with O negative blood. And coagulopathy, it is mainly dilution coagulopathy, what you see here, with the dilution of fibrinogen. So we have to replace fibrinogen here, and the best available product is the cryoprecipitate, because fibrinogen is not freely available. The best one is fibrinogen if possible, but because FFP has very little fibrinogen. So therefore, cryoprecipitate is the preferred the blood component to correct fibrinogen, the reduced fibrinogen. So the medical control, you all know, I have to quickly go through because I have to give some time for questions as well. So oxytocin, augmentin, and prostaglandin, all you can use. So misoprostol or carboprost, IM, you can use. Then the use of tranexamic acid has been shown to reduce deaths by 1/3. So early use of tranexamic acid, 1 gram, and then repeat it after 30 minutes, 20 to 30 minutes. And then you have to replace volume with blood here. You replace the blood loss with blood, not with crystalloid or not with tetrastarch or albumin. Don't use those solutions, but what you have to use is blood, right? With limited, very 1 or 1.5 ml, 1 to 2 ml of crystalloid for the each ml of blood loss. Right. So the replacing blood volume. So start with O negative now. After normal vaginal delivery, it is very unlikely to have cross-match blood. So you will have to start with O negative or group specific. But you know the blood group most of the time in these pregnant mothers. In the antenatal records, you can see that and start with the group specific and then start the cross-matching. Try to keep the blood pressure at least 80 systolic for the mean arterial pressure around 55 to 65 during resuscitation. That is, they don't let the blood pressure to become unrecordable. Right. So within 45 minutes altogether, patient should come to the theatre if there is continuing bleeding. So within the first 15 minutes, the emotive should be completed. Within the next 15 minutes, informing the consultants, getting the senior involvement, informing the transfusion specialist, and the resuscitation should continue. And then within the next 15 minutes. So altogether, between 30 to 15 minutes, the patient should come to the theatre without delay. So that is the important thing. The timing is very important. More you delay the surgical control, the more the complications we have to expect. So anesthesia for surgical control of bleeding. Now here the patient is cardiovascularly unstable and you can't think of giving regional anesthetic. It is general anesthesia. So aspiration prophylaxis, difficult airway trolley, all should be they are ready, and then the most experienced anesthetist should intubate here. Because we can't delay things here, right? And ketamine and suxamethonium are the preferred drug in such a situation with the modified rapid sequence induction with intubation, cricoid pressure. And then broad spectrum antibiotics should be given, and urine output also you have to look for and try to maintain urine output. And the next most important thing is to manage the coagulation, the dilution coagulopathy, right? So you can use rotem guided, or if the rotem is not available, the shock pack treatment can be started, and while avoiding hypothermia and correcting calcium. Now, when you give more than 4 units of blood, invariably you have to replace calcium also. So there are, evidence-based metabolic and these goals, and to try to keep HB at least above 8 during the bleeding phase. The fibrinogen level, of course, though you can't get the report immediately, so you can't go by the serum fibrinogen. That is why the rotem become very valuable at this situation. The FibTem A5 is the one which the most important test, the rotem test in postpartum hemorrhage. If we can have FibTem A5, which indicates the fibrinogen level, so that is the most deranged coagulation factor in PPH. So that is the one we have to replace. So we have to keep it more than 12 millimeter in the rotum graph, right? So we have to replace that. So here you can see the rotum normal rotum report, the normal figure. And then so FibTem A5 is the one here on your right hand side is the FibTem here. This one is the FibTem. Now you can see with dilution how it it becomes the lowest. You can see the picture with the dilution. It becomes just a straight line, right? So by looking at the picture itself, the graph, rotem graph, you know now fibrinogen is deficient, and you have to replace. So it is without waiting for the numbers. By looking at the graph itself, we should be able to predict. Right. So this is the flow chart, how to replace. So when the rotem is not available, the most important factor to replace, as I said, is the cryoprecipitate. So give a cryoprecipitate 20 units to start with. And then you can get the transfusion specialist advice on further factor replacements. Right. So this is just to show the algorithms which you can use when using rotem guided management and the dose calculations. Right. And post-operatively, the patient should be managed in a ICU and with continuing because there is a possibility of rebleeding also, need to resuscitate and complications may develop. Right. I'm going to do the next case because there is no time. Right. So, what are the messages I want to give you is that pregnant mother is the best and the worst event that an anesthetist could meet. The best because it appears very simple and easy to do, a cesarean section, just to give a spinal, right? But the worst thing because the dream may turn into a nightmare with within a very short period of time, right? So therefore, learn to anticipate potential problems, plan and manage accordingly. Ask for advice if you are not sure, and read the guidelines and refer back to them regularly, and keep your the knowledge updated, and improve your skills by participating in workshops and so on, and discuss the controversial issues regarding patient care. Thank you.